Welcome to the training video for the Sonographic Evaluation of Central Line Placement, or CLiP study. The objectives of this presentation are to provide information about our study to research associates as well as healthcare providers, to train research associates to recruit patients and collect study data, to train providers to alert research associates to eligible patients for enrollment, and to train providers to obtain the necessary ultrasound views for this study. Ultrasound guidance for central lines, especially internal jugular lines, is a standard of care. Multiple large studies, including the SOAP studies, have concluded that ultrasound guidance reduces needle temps and complication rates, as well as improving success in obtaining central venous access. However, the chest X-ray is still routinely used to confirm adequate line placement, as well as to rule out complications such as pneumothorax. A line that is adequately placed should be within 2 centimeters of the sinoatrial junction. A line that is too proximal to this has an increased risk of thrombosis. A line that is in the right atrium or the right ventricle has an increased risk of dysrhythmias as well as wall rupture or injury. The disadvantages to this current approach for line placement are, one, that the time needed for a chest X-ray to be obtained post-placement delays the use of that line, and thus medications such as antibiotics, blood products, or vasoactive medications. Second, a chest X-ray performed after the procedure ends, so it cannot detect complications that may be corrected while the provider maintains his or her sterile precautions. Third, a chest X-ray is a poor modality for detecting pneumothorax in the supine patient. Its sensitivity borders about 50%. This is important as the patient on positive pressure ventilation may more readily and quickly develop a tension pneumothorax from a relatively small pneumothorax. Many researchers believe that ultrasound may prove a better modality in confirming line placement. The advantage would be an ability to assess for complications during or immediately after the procedure and before the sterile field is compromised. This would allow for correction of the misplaced line or immediate management of a pneumothorax. Secondly, the ultrasound provides for direct visualization of the central venous catheter within the lumen of the vessel. Third, it is highly sensitive for detecting pneumothorax in the supine patient with a sensitivity above 95%. And last, there is no radiation exposure for ultrasound that there is with plain radiographs or CT scans. There are disadvantages with ultrasound in line placement. First, it is heavily operator dependent. Often, it requires at least 100 scans before an operator is proficient in many of these views. Second, it requires longer bedside evaluation. Third, it cannot directly visualize the tip in relation to the sinoatrial junction. Prior studies have looked at specific stable populations, such as those undergoing elective surgery in the OR, or they were case reports or small studies. Our study will focus on patients that emergently need central venous access, which is typical of most patients that need central venous access. It is also one of the first studies to incorporate multiple specialties, from emergency medicine to critical care and surgery. If we are able to demonstrate that bedside ultrasound is a reliable modality for confirming central line placement, the next step would be to demonstrate this in a randomized clinical trial, in which ultrasound will be able to affect clinical management. The ultimate goal is to demonstrate that ultrasound is just as reliable as chest X-ray in confirming central line placement and detecting complications. The study design is as follows. Once a central line is placed or a decision is made to place the central line, the treating team will alert the study team that a patient may be enrolled for the study. The research associate will assess eligibility criteria and, if eligible, will enroll the patient. The central line will be inserted and the sonographer will obtain his or her ultrasound images. The sonographer will then relay their interpretation to the study team. The chest X-ray may be done prior to ultrasound scan, but the sonographer must be blind to both the image and the interpretation. Once the formal interpretation of the chest X-ray is made, the research associate will record the results on the data sheet. Finally, the study team will review and analyze the data. There are key points to the study. First, while the research associates will routinely approach their providers regarding patients that may be eligible for the study, The treatment team should alert the research associates as well to potential study patients. Second, the sonographer will be a pulmonary and critical care fellow or attending, or they may be an emergency medicine attending or resident. Residents that are not trained to perform these scans will not be performing the ultrasound scans for these studies. Third, the sonographer must not see the chest x-ray or know of any interpretation of the chest x-ray prior to performing their ultrasound scan. And lastly, the interpretation of the ultrasound scan should not be relayed to the treating team in order to change management. The treating team should not base patient management on the ultrasound images or interpretation. Patients are eligible for the study if they are over age 18, if they are not pregnant, and if they require a central line in the subclavian vein or internal jugular vein. They must be capable of providing consent or have a surrogate that can provide consent on their behalf. What if the patient can't consent? A common problem that arises is that the patient will be altered and lacks the capacity at that time to give consent. The study team will attempt to obtain consent from a surrogate, such as a family member or spouse. However, if no surrogate is available, the study team will proceed with obtaining the time-sensitive and necessary data for the study, namely the ultrasound scans and interpretations. The study team will continue to attempt to obtain consent for study enrollment when the patient's condition improves or a surrogate is available. If consent is then obtained, the patient will be enrolled in the study, and the incomplete data will be collected at that time. If consent is not given, then the patient and the ultrasound scans will be excluded from the study, and the data will be deleted. In order to use ultrasound to confirm central line placement, we will obtain 4 views. The first is the central line catheter within the lumen of the vessel and just 1 to 2 centimeters distal to the insertion point or closer to the heart. The second view will be that of the central veins to assess for errant migration of the catheter. For example, if a right IJ is placed, the sonographer will obtain an ipsilateral subclavian view as well as a left IJ and a left subclavian view. We recognize that some views may be more difficult to obtain, so we leave the number of views to the sonographer. The third view will be of the pleural interface, specifically looking for movement between the visceral and parietal pleura. The last view will be a cardiac view of the right atrium, while approximately 5 to 10 cc's of normal saline is used and flushed via one of the central line catheters. For the first view of the catheter within the lumen of the vessel, we will use a high-frequency linear probe. We will place it in the short axis, similar to the method for ultrasound guidance and internal jugular placement. Starting from just distal to the insertion and moving in the direction of the heart, a standard 6-second clip will be adequate to visualize the catheter in the lumen at 2 points. If there is any doubt, the probe may be rotated 90 degrees to obtain a long axis view of the catheter within the lumen. This is an example of the catheter within the lumen of the internal jugular. There is shadowing at the top of the screen corresponding to about 11 o'clock, and it tracks towards the lumen. This is the catheter descending into the lumen of the vessel, which we see now when we overgain the image as a hypoechoic circular structure. In this long axis view, as seen in this image, the catheter is a hyperechoic linear structure that is clearly within the lumen of the vessel. The next set of views to obtain concern misplacement or migration of the catheter away from the SA junction. Remember that an adequately placed central line travels down the SVC and terminates within 2 centimeters of the sinoatrial junction, as indicated by the arrow on the image on the left. A misplaced central line can migrate from the ipsilateral subclavian to the ipsilateral IJ and vice versa, or it can migrate to the contralateral side to the contralateral IJ or subclavian. These are 2 examples of misplaced central lines as seen on chest x-ray. The image to the left shows the right subclavian that has migrated to the ipsilateral IJ. The image on the right shows the right subclavian that has migrated to the contralateral subclavian. To assess for a misplaced catheter via ultrasound, we will first use a linear probe. We'll obtain single views of the vessel lumen in short axis, and we'll overgain in order to detect any catheters that are errantly in the lumen. We'll obtain as many views of vessels as possible, recognizing that some vessels are harder to image on ultrasound than others. To obtain a subclavian vein view, orient the indicator to the patient's head and at the midclavicular line, or where the clavicle angle starts to flatten medially. The green bar on the left image is where the probe should be placed. From this position, scan laterally to image the subclavian vein. Oftentimes, the subclavian vein is directly under the clavicle, so it may be helpful to pull the ipsilateral shoulder inferiorly so that the subclavian can be displaced inferiorly. The image on the right shows the corresponding ultrasound image with the clavicle to the left or closest to the indicator. The subclavian vessels will run anterior or superficial to the lung pleura, so use a visceral parietal pleural interface as a landmark, as well as the clavicle for the superior border. The subclavian artery has thicker walls and is usually smaller than the vein. In this image, the artery is anterior to vein, but this may change over the course. Color Doppler may also help to distinguish the two, as pulsatile flow may indicate artery, while constant flow would indicate vein. Once the location of the subclavian vein is established, overgain the image to detect any errant catheter in the lumen. The next view to obtain is to assess for pneumothorax. We'll continue to use the linear probe, indicator still pointed towards the patient's head. We'll scan at the ipsilateral side of the needle insertion at the second to fourth intercostal space. We'll ensure also that the probe is perpendicular to the skin surface and, in fact, between an intercostal space. From this, you should obtain an ultrasound image as we see on the screen. This is a color diagram of the previous ultrasound image. What we see is that essentially between the probe and the layer represented by 6 is the skin. Below that is the subcutaneous space, and below that, and represented by number 4, are the pectoralis and intercostal muscles in cross-section. 1 are the ribs, and 3 are the neurovascular bundles that are traveling inferior to the ribs. The visceral parietal pleural interface is represented by the blue line labeled 2. In a normal lung, the visceral and parietal pleura are tightly opposed. Inspiration or expiration will result in the sliding of these two surfaces, which on ultrasound appears as sliding or shimmering. Some point out that this may appear to be ants marching. This indicates that there is no pneumothorax. When there is no shimmering or lung sliding, there are two major causes. The first is pneumothorax, or air intrusion between the parietal and visceral pleura. The second cause is more nonspecific and may be seen in apneic patients or those with low tidal volumes, such as patients who are ventilated with high PEEP or patients that have chronic obstructive lung disease and suffer from hyperinflation of the lungs. The last view to obtain is for assessment of correct tip placement, or within 2 centimeters of the sinoatrial junction. This is a two-person technique. The sonographer will first obtain an appropriate view of the right atrium and begin to record a 6-second clip. In the meantime, the assistant will inject about 5 to 10 cc's of normal saline via one of the central line ports. If the central line is appropriately placed, then normal saline will appear as temporary opacification of the right atrium and right ventricle. If the catheter tip is not placed in the correct position, there will be a delay in opacification or no opacification at all. In order to obtain a view of the right atrium, use the P21 or cardiac probe. You may obtain a subxiphoid view, a parasternal short, or apical 4-chamber view of the heart. We recommend, however, that you attempt the subxiphoid view first, as it is easiest to obtain, followed by the parasternal short, and then the apical 4-chamber view. In certain patients, especially those with morbid obesity or those that have underwent abdominal surgery, the parasternal short view may be preferred. The image on the top shows the probe location for the personal short, apical four-chamber, as well as the subxiphoid views. The image on the bottom shows the different axes of the heart that are obtained from these views. The short axis corresponds to the personal short view, and it's in the yellow plane. The blue plane shows the personal long axis view, whereas the green plane shows